All right, guys, we're going to go ahead and get started. Again, welcome to our meeting today. We're going to get started with a few announcements. I'm going to share my screen here. All right. So I just wanted to let you know a few things that are happening and coming up with not only with our chapter, but with our partners and on the national level. So here you see the save the date for the Georgia Infection Prevention Network Conference that's happening in September. So definitely be on the lookout for more information about registration. There will be a pre-conference on September the 27th. And there will also be a CIC review course. So it's more information to come. So just keep that on your radar. Here's some other opportunities that are coming up with national. There will be a CIC certification virtual preparation course that's happening on June the 12th, and you can register at apic.org. National is also having ambulatory surgical centers and outpatient infection prevention training in July. So this is a virtual class. And then of course there's Epi Intensive at the same time as the ASC training from July 18th to the 21st. And all of these, again, you can register at apic.org. Another thing I wanted to mention is that the Department of Public Health, in partnership with Alliant Health Solutions and UGA, is having an office hours event for skilled nursing facilities. So the staff and the administration are invited to attend. It's happening this Friday, May 20th from 11 to 12. And I will post that registration link in the chat for any of you who are interested in attending this event. And I will now turn it over to Jessica Terabay to make an announcement about some outreach opportunities or meeting opportunities that we have coming up in the future. Let's see, I don't think Jessica is on right now. I think what she wanted to ask was who all was coming to, who's always going to be in person at National APIC. And if you are, if you could just put your name in the chat saying, I'll be there. What we're trying to do is just have sort of a meet and greet for those of us who'll be attending in person next month. So yeah, when you get an opportunity, just in the chat, just say, I'll be there for APIC National, and we will go from there. All right. Other announcements that we have. Again, we are the recipient of the Chapter Excellence Award for Synergistic Alliances, meaning we got awarded for working well, not only within the chapter, but with external partners as well. So there'll be more to come about that award. We will be receiving an award at National APIC. So I'll be sure to share what that looks like with you all at our meeting coming up. This is our last general meeting for the next couple of months. We'll reconvene again in August. So just be on the lookout for upcoming events that we'll be having throughout the summer. And again, for the meeting that is happening in August. All right, so I'm trying to see if it's anybody else on the board that had any announcements that they wanted to make in addition to what I just said. I'll give you about a minute or so to speak up. Well, all right. If not, I see that Ms. Denise Leaptrot, our presenter, is on right now. So I'll go ahead and introduce her, and then I will turn the floor over to Ms. Leaptrot for her presentation. So again, Denise Leaptrot is an infection preventionist and epidemiologist for the Centers for Disease Control and Prevention and the Division of Healthcare Quality Promotion and Surveillance, where she is a member of the National Healthcare Safety Network, our lovely NHSN protocol and training team. In this role, she provides consultation and technical assistance regarding surveillance for healthcare associated infections using NHSN. Denise covers all areas of NHSN with emphasis on multi-drug resistant organisms and C. diff, as well as surgical site infection surveillance, and is a multi-published author in these areas. She has more than 25 years of combined experience encompassing healthcare epidemiology, infection control and prevention, information technology, and educational efforts within the public and private healthcare arenas, as well as the public health sectors. Denise holds a master's degree in business administration with a focus on management and statistics, a specialty in microbiology, and a bachelor's degree in medical technology with accreditation by the American Society of Clinical Pathologists. She has been certified in infection control for more than 20 years and counting. Again, we are very happy to have you, Ms. Leaptrot. You can go ahead and share your screen and start your presentation whenever you're ready.
Thank you so much. Could I just get someone to verify you can hear me okay?
Yes, we can hear you.
Great. All right. Let me just pull this up and get it in presentation mode. I wanted to say 25 years and counting for CIC because I restarted just this past year using the new CEU-based process. And it was so much more incredibly easy for me. I have done the SARE a number of times, and I am really on board with this new CEU process and would encourage anyone who is eligible to try that should they want to be certified soon. So today, thank you for asking me to join you. Many of the members of Atlanta APIC are colleagues of mine, as well as personal friends. I'm very happy to have a chance to be with you today. I have missed that interpersonal action that we have benefited from in the past, but my presentation today I've entitled The State of NHSN, and what I'm going to do, hopefully over just the next few minutes, is to speak briefly about where we've been from the NHSN perspective, where we are currently, and where we plan to be moving forward. I have tried to build in time for questions at the end of the presentation. Certainly I can't do any specific case reviews, but if you have questions that are just generally about NHSN, or certainly anything that comes up in this presentation, I'll be happy to answer those at the conclusion of my presentation. So what is NHSN? Pretty much everybody should know that we are the National Healthcare Safety Network, which is a data depository for the most part. We live within the Centers of Disease Control and Prevention here in Atlanta. Our main campus is right here off Clifton. And the team is made up of trained IPs and public health specialists who provide good clinical expertise for the data that we are collecting from the different facilities reporting into NHSN. We do collect data by individual facilities so that we can have facility-specific rates available for each of you. We do a lot of case reviews for the individual facilities. Our primary means of communication is our email center, and I'm sure many of you have written to us, and perhaps I have answered a question or two for you. I hope I have anyway. Let's see if I can get my screen to advance. There we go. So who are we? I need to, let's go back. Sorry, I'm trying to use a dual screen and it's a little bit of a new endeavor for me. I thought it would be nice for you to be able to put some faces with the names that you may have been communicating with. So this is our current NHSN team. We're led by our lead person, Henrietta Smith, who many of you probably know. She's been a member of the Atlanta APIC for many years. Others that are on our team are myself, Latasha Boswell, Dominique Guthrie Johnson, Emily Witt, Marissa McMean, Melissa Otis, Vicki Russo, and Jennifer Watkins. Together, our years of experience is well over 100 years of specifically infection prevention experience. And so we feel like our day-to-day activities where we are intimately drilling into the NHSN protocols and definitions put us in a really good position to help our users with difficult situations and to guide you with new situations. We go by a lot of names, as you probably do yourselves. You know, they call us germ detectives. The favorite reference to our protocol and training team currently here at CDC are unicorns. And that's because we're really special, as all of you are, and you know that. We support a lot of healthcare facilities, greater than 37,000. That's about 10,000 acute care facilities or hospital-based acute care facilities. We have many, many individual users, and we are apt to receive emails from any of these on a daily basis. Our team is comprised of 10 IPs. We have a couple of openings right now that were recently filled, so we've got some new people that'll be joining, but normally there's 10 of us that collaborate. We oversee the surveillance definitions and the guidance that we provide through the Patient Safety Manual, or the NHSN Manual, as we like to call it. We review these pretty regularly. Everything is done no less than annually. Sometimes it seems we are called to review things more often than that, however. But this is our Bible, so to speak, our NHSN Manual. Over time, we have seen this move to a more technology orientation, and I'm going to speak a little bit more about that in the later slides. But our primary purpose has always been to collect data in a consistent and meaningful manner so that we can make it available back to our users. They can use the data to identify improvement opportunities, and hopefully that translates to improved patient care practices as well. So I like to use this just because I think it is a very realistic representation of the IP world. It might be just a little blurry because I copied it from a friend of mine who graciously allows me to use it. But in the first frame, you have pictures of what my friends think I do. And that's always all about hand washing. That seems to be the one piece of IP work that resounds with the general population. So if you're talking to your family and you're trying to tell them a little bit more about your work, you're probably talking about the germs and how you can actually grow them in a setting and see them. But when the media gets a hold of what we do, it's always the extreme. We are dressed up like space people, and we are trying to protect ourselves and the world from some sort of a germ insult. So when I talk with my colleagues, I'm always buried in some sort of a research project. And I have this vision of piles and piles of books. But what I think I do is I'm finding a cure, and I am making that available to the world. But in reality, what I do, and probably what many of you do as well, is we sit in front of the computer and we just delve into every situation from an electronic perspective. I think the days of where we are getting into printed records are behind us. I know that in the acute care hospitals, there's been this move to try to get our IPs out from behind the desk and back onto the floors. And I hope that that continues and will be successful. But a great portion of our work is greatly tied to electronic means and processes. So this is what the NHSN reporting train looks like. You've probably seen this before, but it all does start in our patient safety component, which is where we have our NHSN manual, where the guidances and definitions live. But we also have other modules for reporting. The long-term care, which is the nursing home component, has increased quite significantly over the last couple of years, as has the outpatient dialysis component. The healthcare personnel safety component is where you are now reporting your flu vaccinations and your COVID-19 vaccinations. Biovigilance is for transfusion reactions. The outpatient procedure component is for our ambulatory surgery center reporting. And our newest component is our neonatal component, which we kicked off last year. And the first module within the neonatal component is the LOS-MEN, which is the late onset sepsis meningitis module for reporting neonatal infections. If you look at the patient safety component, and the primary focuses of reporting is going to be associated to medical device, surgical procedures, and antimicrobial agents that are being used in healthcare, with additional emphasis on our MDROs, our drug-resistant organisms. So under the device-associated module, you're familiar with CLABSI reporting. We have our CLIP adherence under the device-associated module, CAUTI reporting, ventilator-associated event reporting, including the PVAE for pediatrics. Pneumonia is also under the device-associated module, although perhaps pneumonia is not a device-associated event specifically, but it is very closely aligned with our ventilator-associated event reporting. So those things all fall under our device-associated module. Separately, under the procedure-associated module is where you'll find your SSI reporting. Separately, again, we have an AUR, or antimicrobial use and resistance module, and then our multi-drug resistant organism and Clostridium difficile infection module, MDRO-CDI module. I will just go ahead and mention that we're in discussions to retire the central line insertion practice, the CLIP module. I don't know if any of you may be using that module. It would remain available, but we would not support it if it were to be retired. So training is one of our major efforts, and we do annual training here at the CDC, and then we participate in many national trainings. Unfortunately, we have not been able to travel to trainings for the last 2 years. And again, this year, we were unable to travel to the APIC National Conference. We have already provided some on-demand trainings that APIC will be making available to all of their attendees. All of our annual trainings are recorded and placed on our website so that you can listen to them as many times as you need to. And this is updated several times a year as new trainings become available. The trainings that we do, either live or on demand, are usually a little more lengthy than some people can make time for. So we also have created what we call some quick learns and some lectoras, which are shorter training opportunities. And I would encourage you to visit our training page and see what opportunities may be available for you. I have put the link directly to the training page here on the left side of the screen. I also wanted to kind of pump up the volume a little bit on our AGIC collaborations for case studies, which are published about a quarterly basis. We try to provide AGIC a case study every quarter for printing, depending on what type of space they have. I have added a link here for our most recent AGIC case study, which is an SSI case study. This is a personal link that they sent to me that I could share. It's active for 90 days, I'd say we're about 15 days into that now. But if you are an APIC member, you have access to AGIC. We have asked AGIC to make all of the case studies a on-demand type of free access. So if you're interested in getting some additional training, these are good case studies that cover specific areas. And we've done in the past BSIs, we've done UTIs, we have the SSI one, we've done a pneumonia one. On the horizon, we have a validation study in the works. We have a secondary BSI one in the works. And these are just really good ways for the individual or for groups to review a specific case and determine whether or not you can make correct determinations. We have particularly recommended to IP teams with a lot of different people so that you could kind of test your interperson reliability of how the application and its guidances are being applied. So that's kind of where we've been and where we are. So let's talk for the next few minutes about what you can expect going forward. As I mentioned, we recently launched the neonatal late onset sepsis and meningitis, the LOS MEN module. That is in production currently and available for use since late last year. Most of our new projects are going to be digital quality metric based projects. And by that, I mean these new modules, when introduced, will be a totally electronic type of a data capture. They will not offer an opportunity for any type of a manual entry or edit. So currently, the electronic/digital means for providing or participating in a module is going to be a CDA file upload from the facility into NHSN. And that's how LOS and MEN works. Also in development, you'll see we've got venous thromboembolism and the respiratory pathogens module that will cover COVID-19, RSV, and flu at the onset. Both of these modules, again, are intended to be a digital module where you would provide a CDA file to us and we would scrub it and apply the rules of the module to the data and then turn the data back around to you so that you could review it and use it to identify opportunities for improvements. I'm not confident that I can give you a date on those early development modules right now, but we do have work groups that are actively working on that module. Under the coming soon column, you'll see that we have glycemic control, hypoglycemia, hospital onset bacteremia and fungemia, what we're going to term the HOB module. And we have a revised C. difficile measure, which will be a new module, separate and unique from our current Lab ID event reporting module. We're calling this module our HOT CDI module, which stands for Hospital Onset Treated CDI. And then lastly, there is sepsis stewardship, which is really an offshoot of the AUR module, which is totally electronic already. We also have some planning projects that we're working on. And as you see here, there is a planned project for home health, bloodstream infections, emergency preparedness, infective endocarditis, and a specific sepsis outcome measure. All of these are very early stages, but I just kind of wanted to put them out there and throw them on your radar a little bit. I'm going to talk more specifically about the hypoglycemia, the HOV, the hot CDI, and I'm going to give you a little preview of where we are with the respiratory pathogens. Again, I want to get this on your radar because when we introduce new modules, we really need to ensure that they will be accepted by our reporting facilities and that we'll get data back so that we can verify that these newer definitions and guidances are appropriate. The intent of the hypoglycemia, the hospital onset bacteremia, and the hot CDI is to make reporting less burdensome for the individual facility. We collaborate with many different organizations, and one organization that we collaborate with very routinely is CMS. CMS has said to NHSN, we would like to find a way to report the quality measures that we feel are indicated for improving patient care in a manner similar to how you are reporting HAIs. If you can build a module where we can combine some of these quality metrics in the same manner that you have provided HAI surveillance, we feel like facilities are going to respond to that positively, and we'll get better data and we'll get more meaningful data. So our intent is to try to build some modules that can go out and can pull data from your patient record in a variety of ways. And it will not be directed surveillance for just HAIs. It will be pulling some quality measures as well. There are a lot of things yet to be determined, but as we move into more of a digital age, this is the trend of the future. And we kind of felt like we needed to get on board with that. So let's just talk very briefly about some of these new modules that we're working on. And we'll start with the respiratory pathogens module. So as you can see, we are looking to identify healthcare associated respiratory disease. CMS has indicated that respiratory disease in their patient population accounts for quite a high percentage of all the infective type hospital admissions. So they are very interested in trying to get a better perspective on the level of respiratory disease across America. There are tons and tons of different respiratory pathogens, and it's not realistic to try to capture every single one of them in a reporting mechanism. To begin with, the interest is very high for COVID-19, RSV, and influenza. So those are the three that will be targeted initially with the respiratory pathogens module. So the facilities are going to be submitting the data elements from the EHR via a CSV file upload. And in the application, the surveillance criteria and algorithms will be applied, and then the results can be provided in a dashboard back to the facility. The eventual goal would be to build the RPS analysis into the application so that you can put additional respiratory data in and hopefully use all of your respiratory disease to come up with a plan to combat that type of an illness. We certainly always have an eye towards providing analysis and algorithms that will be used for other entities, in particular our states and local health departments and our territorial colleagues are important. And our hope is to have this module ready for introduction during calendar year 2023. And I really can't be much more specific than that because there are some challenges related to patient level data that have to be worked out, but we are excited that we're going to be able to put together something that's going to be specific to COVID-19 in particular, because we do know that the COVID-19 reporting is kind of scattered at this point in time. You're either probably reporting through Teletracker or HHS. If you're an acute care hospital, if you're a nursing home, you can report through NHSN, but a lot of places report primarily to the state, and then the state sends that data on. So this would be more of a centralized location for data reporting that should improve the data flow available. Here we have just a very, very quick overview of what we're looking at for hypoglycemia. So the hypoglycemia metric would be pretty much all patients admitted to the hospital, no age restrictions. And we're kind of starting with, if they're in the hospital setting greater than 1 hour and there is a glucose reading on the record, it will qualify for either the primary metric or one of the complementary metrics. This new division between a primary metric and a complementary metric is going to be a common theme with all of the modules because there are so much data. We're really very, very data rich if you sit down and look at it. So we are trying to, again, centralize some of the reporting of the quality metrics that are used in the IQR program strictly into NHSN, since we are and have been accepted for reporting by the majority of all healthcare facilities across the United States and even some overseas, but primarily in the United States is where we focus. So I'm just going to give you a minute and let you read through this. Again, this is a pretty preliminary overview of where we are with hypoglycemia. I would not say that we're anywhere close to completing this particular module or solidifying the data elements that are going to be used, but we're working with a group of physician specialists who are guiding us into the pieces of the hypoglycemia puzzle that are the important ones to include in or capture for a reporting metrics. When we talk about inpatient encounters, we are not talking about observation or emergency room visits. Inpatient encounters are inpatient visits. And that's been a little bit of a struggle for me to get on board with because I'm very, very accustomed to using encounters in the context of lab ID event reporting. But what I'm going to have to ask you to do when we start looking at these new modules is to kind of put everything that has been used previously over to the side. Don't forget it, because you're still going to be using our traditional reporting metrics for some time, but we're trying to introduce some new concepts into reporting as well. Let's move on to our hot CDI metrics and our complementary metrics. So again, hot CDI stands for healthcare facility onset antibiotic treated C. difficile infection. I am sure you, like many others over time, have been discouraged by the fact that the current C. difficile lab ID event definition is a proxy measure based strictly on a positive laboratory finding. One of the major complaints is that by using a proxy measure of just a positive lab finding for C. difficile, we're not really having any type of clinical determination of whether we have an active or a colonized patient, and there was no consideration given to something that could have occurred without being considered clinically significant. So all of that feedback has been taken into consideration, and where we have landed with this proposed new metrics is to continue to focus on a positive laboratory finding for C. difficile tests and adding in treatment for the C. difficile condition. This was endorsed by our physician specialist who said, if I look at a C. difficile patient and I think they have C. difficile and I treat them, then they need to be captured in a definition. It will be strictly looking at events that will occur after hospitalization. It's still a little out there for discussion as to whether we are going to define hospital onset on hospital day 3 of an inpatient admission or continue to use hospital day 4 of an inpatient admission to define a hospital or a healthcare facility onset event. There are pros and cons to going in either direction. And again, I don't think one outweighs the other currently in our discussions, but I think the real benefit to adding the treatment is that we will be looking for specific antibiotic treatment. It can't just be anything. We have defined the treatment for acute C. difficile, and only those drugs are going to be eligible for use with this new metric. The complementary metrics will continue to capture community onset events, and we will look at outpatient areas as well as inpatient areas in the complementary metrics. But the key elements will continue to be the positive laboratory finding, and in addition to the medication or antibiotic treatment. Our goal is to launch this module early 2023. We're actually pretty well into development of the electronic measure. So I hope that we continue to stay on the same timeline, and I do anticipate that if we don't get it out as early in 2023 as we would like, we will have it pretty early in the calendar year, in the first 6 months of the calendar year anyway. I will just make note here, because I'm sure everybody is asking, when we introduce these new modules, what does that mean about our current reporting activities? You cannot cease surveillance for your current modules metrics. So you can't cease lab ID event reporting, for example, because it is the outcome measure included in CMS's IQR programs. What our hope is, and what we actually have discussed with CMS, is to run these modules in parallel for a certain period of time, gather data to compare, to see what they look like side by side. And the eventual hope is perhaps the new measure, which should be less labor intensive and easier data collection for the individual facility, will replace some of the current metrics in the IQR program. That is not a decision that will be mine or yours. I do not know what the data will look like, so I can't say how long it might take to run parallel tests and data capture to make it to a point where it could be considered a replacement, but we're kind of working in that direction in the hopes that we will get very good comparable data, a little better data, more likely, because we've added some extra elements that will align more clinically closely to the patient's true picture. Here's the HIV metrics, and it is very, very similar in concept to the HOT CDI. We would like to introduce this module early in 2023. That's our goal. We're working towards that. We want to get it out there. We would really ask that facilities elect to participate in the reporting when it becomes available so that we can begin to gather the data for comparing to our current BSI metric and our MRSA lab ID metric. As you can see, again, we have our primary metric, and then we have complementary metrics. Some individual facilities use the blood culture utilization piece a lot. I think most everybody's looking at blood culture contamination, and currently, you know, we have a LCBI2 definition for common commensals. So the HOB event is going to focus strictly on pathogenic bacteria or fungi. And we will not have a common commensal category for HOB. The common commensal will be a complementary metric. We're looking for blood culture collected on day 4 or later. Again, that might not be set in stone. It could be that we move it back to day 3. But for right now, we're going to say it's day 4. And it's still going to be positive blood culture laboratory finding-based metrics. Just give you a minute and let you read through that a little bit more. So here's how we perceive the data will flow. The facility will report, they'll send the files in through an electronic data submission. Either we've been working with vendors on some of our pilot projects and have made some progress with that area. It could be a homegrown project, or it could just be a CSV CDA upload, but we'll get it into the NHSN application where the business rules and the algorithms for the criteria will be applied. We will analyze and we will provide dashboards for facilities and hopefully by groups, including states and territories, which will be downloadable for convenience. And then we can pass that data on to our collaborating organizations such as CMS and the states and the local health departments and the hospital association. We've used dashboards very successfully with COVID reporting. Everybody really likes dashboards, and can't say I blame them. They're pretty neat if you've had a chance to look at them. So I think that is definitely something that we are wanting to keep and develop more, but this is how we perceive the process will flow. And for NHSN, I think the direction that we're moving is more process-oriented, away from manual entry, manual chart review, and individual case determinations based on circumstances. It will be pretty much based on criteria only going forward. So that's all I have for you today. I appreciate your time and your attention. I will just tell you that the first 5 days after the weekend are always the hardest, and we're 3 days closer to it. I am happy to try to take any questions that you might have that are general ones that I can answer today. Otherwise, I invite you to contact us at nhsn@cdc.gov with particular case reviews or any very, very specific questions that you might have. I will say that I cover a lot of the different NHSN areas, but I would not say that I know every single thing there is to know about NHSN. But isn't that one of the best things about being an IP? It never gets old because there's always a new adventure right around the corner. But again, thank you, and I am open to questions.
Hi, this is Tanu Soni. I'm an infection preventionist at Emory St. Joseph's Hospital, and I am so excited about the new modules and also the fact that NHSN takes our feedback. So that is great to know. I wanted to make a case for sticking with the seed of definition on day 4 or behind being considered as hospital acquired. Through the years, we have worked so hard on our diarrhea decision tree, which is based on your current NHSN definition and hardwired the nurses. And we have a protocol at Emory where the nurses are allowed to place an order for C. diff on days 1, 2, and 3 to capture the community onset. And while there may be a lot of pros, one of the biggest cons of changing the definition is just getting everybody to be educated and start doing the new things, especially given the staffing issues that all hospitals are facing. We already have very little compliance with our testing protocols, and these kind of changes make it so difficult at the front end staff. So just wanted to put that out there for your consideration. Thank you.
You're welcome. I'll be happy to take that back to our CDI group. We're meeting about twice a week on average right now, and early on we even met more frequently. But that HOB area and the CDI area has been kind of twined together. So some of the influence on the day may end up being HOB influenced, but I too agree with it just seems simpler to me to keep the day 4. I'm such a tiny little voice in a big group, but I will make it known. Thank you for letting me have that information.
Thank you. And I am sure that you are you have a much more effective voice than we little IPs sitting in our offices.
Oh, I am your IP sitting in an office though. Thank you.
I see that Crystal Johnson posted in the chat, is 2-step testing still going to be taken into account, or will it be any positive test with treatment? Crystal, would you mind coming off mute to just explain exactly what you're referring to?
Hey, it's Crystal. I'm also from Emory. And I was just wondering, is there going to be any positive tests? So EIA versus toxin?
That is another area that is still up for debate, but I will say that we are leaning towards any positive test. And the reason for that being the difficulty that we have had thus far with determining the final test performed based on the individual facility reporting format. we do still have a capability to do risk adjustment based on what you tell us is your testing algorithm. But we feel like from an electronic standpoint, we're not sure we can differentiate which test is the last test, short of making you put a timestamp on every single test that is performed. So we are leaning towards any positive test would count, and then we would include in the risk model your testing algorithm.
Okay, thank you.
Sure.
Sorry, so for that point, is it not possible when we put our monthly reporting plan to have something, it already gives us an option to choose NAAT and EIA. So is there no possibility to put in which test we ran first?
There isn't a way to do that in our current NHSN application.
Yeah, right.
And because the new module would be basically just an uploaded CDA file, I do not know whether there is potential for that or not. I can certainly ask. That's kind of a developer question, and sometimes it's how the code can be written, whether or not it can be included. So I can ask.
Thank you. I'm sorry, I have a lot of asks.
Okay, we have another question in the chat from Ms. Lisa Floyd, and she asks, can you repeat where to find the AGIC case studies?
Let's see if I'm still sharing my screen. How rude. Let me just go back. Can you see that link on the screen now?
Yes, we can see it.
All right.
Okay.
So again, this is to our most recent AGIC case study on the SSI, which is an SSI case study. And this link is active probably, I would say, for the next couple of months. You might get to it. But AGIC does let you archive. So you could possibly just go through the AGIC link and get back to some case studies if you want other ones outside of SSI. But try this one and let us know what you think about it. You know, we actually work on these. It takes a month or two to put the cases together and get the questions, the knowledge checks in place, and then it's a process to clear through the CDC and then also to clear through AJAC. So it takes a minute to get it published, but a lot of times they'll put them online first before they actually print. And we like to hear what people think about them.
Awesome. Well, again, Ms. Leaptrot, thank you so much for lending your time and your expertise to us and updating us on what's going on with NHSN. I know I personally have benefited from you helping us out, figuring out a few cases here at Children. So again, thank you for your time. And we got another question. Jessica Terabay asks, can we go back to the C. diff testing and treatment? Is it a common practice for prophylactic treatment prior to lab results?
Yeah, hey, Jessica. I just wanted to ask that question again because it is a common practice for prophylactically treating patients. And so like how that would work out as far as the treatment goes and a positive test with it counting as lab ID event.
So the treatment has to be pretty specific for C. difficile. I wouldn't really call it prophylactic treatment, but I do know that it's not uncommon when a patient is admitted to the hospital and they have diarrhea, they'll be put on flagyl, for instance. That's one of the more common medications that's used. So we did discuss that particular aspect of it and whether or not to even include Flagyl as an eligible medication treatment for C. difficile. There are a couple of others, oral vancomycin being one and fidaxomicin being another, that are really much more targeted treatments for C. difficile. And again, it's kind of preliminary, but we did set a window of 2 days before your positive test. So I feel like if you're looking at hospital onset events specifically, Flagyl would have been started too early if it were really prophylactic, and it wouldn't influence reporting. But we'll have to see what the data shows us, to be quite honest. I hope y'all all participate once we get this out there, because we're really going to need the data to be able to confirm what we think is true, is appropriate.
Great, thanks for that update.
You're welcome.
Well, all right. If there aren't any other questions, again, thank you all for joining us today. Thank you, Denise, again for your presentation. We will meet again in August of 2022. We're taking a break for the summer, but we'll reconvene again in August. So everyone, thank you for joining and have a great day.